Bismillahirrahmanirrahim. Welcome to IRA. I'm Dr. Muhammad Talat, Assistant Professor at Africa University. Let us continue our course. And as we said in the last video, the best way to finish our course is to highlight the importance of the CT brain checklist. This young adult patient complaining of seizure attacks. Apparently, we don't have any significant abnormalities. We don't have any specific lesions. Let's save your time and go by one by our checklist. We don't have any extrinsic collections. The gray white matter interface is preserved. The hyperactive region is free. But we have here a space occupying lesion as a pre-pontine systole, left paramedian allocation, and anterior to the basilar artery. It doesn't encase or engulf the basilar artery. And I think it is in front of the interpeduncular systole. This is the interpeduncular systole, and this is the mass lesion going more towards the midline. We don't have any other significant abnormalities. Let's reconstruct the image and let us see the sagittal plane. In the sagittal plane of the patient, we have here a pedunculated mass specific lesion, and this mass lesion is extending inferiorly to the prepontine systole. This is the bones, and this is the prepontine systole. The mass doesn't extend to the suprasellar systole. This is suprasellar systole, and the mass lesion most likely attached to the side of the tuberosinium or the hypothalamus. So most likely this is a hypothalamic mass. One of our most important differential diagnosis in this case is hypothalamic hamartoma. Hypothalamic hamartoma can explain the seizure attacks of the patient. Second differential diagnosis for this case is hypothalamic glioma and hypothalamic metastatic lesion. We have a list for differential diagnosis for the hypothalamic masses, but in this case, contrast-enhanced MRI scan is very important for better characterization. Let's move to our next case. This case, non-contrast scan of the brain for an adult patient. Really, I don't have enough history for the patient. But apparently, we don't have any areas of rich blood density, no brain edema, no specific lesions. Let's apply our CT brain checklist. We don't have any extrinsic collections. Gray-white matter interface is preserved. Go point by point by your checklist, and you will find something abnormal here at the skull base. Something like posterior lesion. Let's review this case in bone window to save your time. So this bone window for the same patient confirms that we have lytic lesion with non-sclerotic margin involving the right aspect of the clivus, and this lytic lesion extends superiorly to involve the basis sphenoid. And also this lytic lesion partially erodes the carotid canal at this area. This is the carotid canal, and this part is partially eroded by the mass lesion. So we have an aggressive lytic lesion, right paramedian allocation, involving the clivus and the basis sphenoid, with an extraosseous soft tissue component protruding inside the sphenoid sinus. In our routine practice, once we have lytic lesion involving the clivus, you should ask yourself, is it midline or paramedian? If it is midline and aggressive posterior lesion with large extraosseous soft tissue component, you should think that this case may be chordoma, because chordoma involves the primitive notochord at the midline of the axial skeleton. Most likely involves the sacrococcygeal part and the skull base, especially the clivus. But we have here, in this case, the lytic lesion is right paramedian location, not midline. You should ask yourself again, is there any chondroid calcifications? We don't have any chondroid calcifications. If we have chondroid calcifications in right paramedian lytic lesion involving the clivus in an elderly patient, chondrosarcoma one of our possibilities. So again, I think it is not matching with chordoma or chondrosarcoma, but we should also put these possibilities in our differential diagnosis. But I think the most likely differential diagnosis in this case lytic lesion, right paramedian. I think metastasis one of the most important possibilities, and you should raise possibility of lytic lesion or lytic metastatic lesion for metastatic workup. Let's move to our next case. This is an elderly patient, non-contact scan of the brain. We have for a little bit relatively periventricular hypodense areas, keeping with early chronic ischemic changes. But we don't have any areas of fresh blood density. We don't have any specific prime lesions, no brain edema, no midline shift. Brainstem and cerebellum are normal. And let's apply our CD brain checklist. To save your time, let's see the bone window. Bone window of the patient. You should check the skull base, one of the most important hidden areas on the non-contact scan of the brain. You should check the bone window, and you should check the vessels, arteries, and dural venous sinuses in every case of non-contact scan of the brain. And if we need to check the bone window here, I think it's hardly seen that we have something like lytic lesion at the petrous apex. You will find here, look for this one. This is the cortex of the clivus. Look for this cortex. It is much eroded. This area shows an aggressive lytic lesions, aggressive osteolytic lesion involving part of the petrous apex and part of the clivus. This one is abnormal. It doesn't look like the contralateral side. Let us review the rest of the skull. I think here may we have something like lytic lesion, but I'm not sure. Also, the diploid spaces here and here, we have suspicious of lytic lesions. So we recommend to do contrast enhanced MRI scan for this patient to confirm and to check the rest of the skull base bones and skull or clivarial bones. We did MRI of the same patient, and once we concentrate more on the clivus, this is the normal signal of the clivus, fatty signal, while all of this area is considered as marrow infiltrative lesion. So we have an ill-defined marrow infiltrative lesion involving the petrous apex on the left side and the left aspect of the clivus. The nasopharynx is normal in its appearance, so we don't have any nasopharyngeal tumor. We have also here, this is the normal diploid space fatty signal or hyperintense signal in T1, but this area is considered abnormal in the frontal calvaria bones. So we have suspicious of osteolytic lesions or metastatic osseous lesions involving the skull base and the calvarial bones. One of our message here, really, I learned this one from one of our professors, Dr. Luay Azad, Allah yarhamu. Dr. Luay, one of our professors of radiology in Cairo University, he taught me that every case, every MRI brain, you should check the skull base, check the fatty signal, the hyperintense signal in T1 of the skull base in every case. And this one of the hidden areas, in CT brain and MRI brain. By the way, this case proved later on that this patient had prostatic carcinoma with extensive osseous deposits, widespread, involving many bones. By the end of this course, I would like to thank you all for joining us and for supporting us, either with comment or watching our videos. And even some of you press like or dislike. I would like to thank you all. And again, if you have any comments, I'm happy to see your comments. And if you have anything that you want to change later on in next videos or next courses, I'm happy to see your comments, and I'm happy to receive your feedback. And if you have any suggestions for the next courses, I'm happy also to see your suggestions. Which branch, which type of courses would you like to concentrate in the next courses, inshallah. Thank you so much.